Namaskar, Hare Krishna. Today there is an interesting case which I wanted to share with you. Of course, this team is going to share this case with you. She is a young patient, primary gravida, 28 weeks period of gestation. She came to us as a case of acute respiratory failure. She was initially managed on acute respiratory failure on the conservative means, which means the patient was initiated on oxygen therapy, the fluid conservative strategy. The patient was also given NIV trial. But given the fact that the patient continues to worsen in terms of respiratory failure, and the PF ratio means PaO2 by FiO2 ratio, which was less than 100 in this case. So eventually the patient was fitting into the category of severe ARDS. Now, when you have a case of severe ARDS, obviously they need tracheal intubation and the lung protective ventilation strategy, right? So these are physiologically challenging, and their intubation is very precarious, very difficult, and at times during the intubations, we have seen they critically resaturate and they can even land up into cardiorespiratory arrest. With the help of ICT, this patient was successfully intubated. But what was very interesting, which I wanted to share in this compendium along with our team, is that when you have a case of ARDS, which is severe in terms of the PF ratio, what is a standardized management of Ankit, which you think we have to give to every ARDS patient who is critical enough to be ICU? What do you think?
Patients who are coming in very critically means respiratory failure, and those PF, as you said, PF ratio was less than 100. So in such a strategy, in spite of not maintaining saturation, not having good saturation, not oxygenating them, only one strategy we used to do in our ICU. We used to have prone ventilation.
So prone ventilation, yeah, this is where I wanted to make the people aware about. The prone ventilation is a standardized way of treating the patient with an acute respiratory failure, right?
Yes.
Especially when the PF ratio is less than 150, which is based on the guidelines which are PROSERVA guidelines. And now even in the Surviving Sepsis campaign guidelines, they are clearly saying that all the patients who are having a PF ratio of less than 150, they need to be intubated, they need to receive low tidal volume lung protective ventilation. And before you try anything further invasive, which means venous ECMO or VA ECMO, depending upon whether they are having a hemodynamic instability or not, you must prone the patient. So idea is what? Every patient with the ARDS has a differential, which means non-cardiogenic pulmonary. So they need to receive the prone ventilation trial before you call them as refractory in terms of their hypoxemia, in terms of their hypoxemic respiratory failure. So, but having said so, Dr. Ankit, what is unique about this patient, which you think is going to be interesting for our audience who are going to see and witness this case?
Yes. The unique and interesting case in this case is that she's a pregnant female.
So pregnant patient, almost second trimester, end of the second trimester.
Second trimester, gravity uterus, 28 to 27
28 weeks.
28 weeks of pregnancy. In such cases, doing proning, because we are dealing with two lives.
Yeah.
Yeah. So doing proning in such patients, because we have to take care of two lives. Uteroplacental circulation has to be maintained. All the vital thing that we have to maintain in this. So doing prone in such cases is very challenging.
So prone is something which is a standardized protocol for all the patients who are having a severe ARDS, where the PF ratio is less than 150. Having said so, performing a prone ventilation, there has to be a checklist which you must be able to exclude that my patient should not be having any contraindication to prone them.
Yes.
And one of the standardized contraindication for them is when you have a patient with a spine injury, or the patient who are having a raised ICP, the patient who has an unstable cervical spine, the patient who have an obvious thoracic surgery where there's an open chest. Now, I wanted you to focus upon that the patient who is having a prone, especially in a pregnant patient, it's going to be challenged because your patient who is placed in a prone may have a direct pressure effects onto the abdomen. And as Dr. Ankit has said, because of the direct pressure effects, it can geoparadize the uteroplacental circulation. So what you think specifically you have to do when you're going to prone a patient who is otherwise pregnant? And maybe, Dr. Munashira can also join with us. So what do you think which we have to do, especially when we are dealing with a pregnant patient who's going to be prone. Anything specific which you feel is different in the pregnant population in comparison to a non-pregnant referenceable population?
Although we have to free the abdominal area.
Very nice. So the point here is that the direct pressure effects
Yes, it
has to be avoided.
has to be avoided.
Has to be avoided. Okay, that is one.
That is one.
So where do the bolsters has to be placed? The pillows.
At the level of the flanks.
So there has to be at the level of pelvis, or maybe the flanks, or maybe at the level of, and the one has to be at the level of chest, at the level of chest, and this abdomen has to be free. So that is very important. So the direct pressure effects of the bolsters, which can geoparadize, which can have a direct pressure effects onto the uteroplacental circulation, has to be taken care of. Anything else?
Along with this, we have to continuously fetal heart monitoring is to be done.
So second important point which Dr. Ankit has said, so the continuous fetal heart rate monitoring. So are we doing this case with a fetal heart rate assessment?
yes, we are doing in this case.
So fetal heart rate assessment has to be done. If not continuous, then at least after every consecutive intervals, let's say after every 4 hours, 6 hours, at least if you're not doing the electronic base, then at least the auscultation based fetal monitoring has to be done.
Yes.
And what is very important, what do you think, Dr. Manish, when you have a pregnant patient and you also have a live fetus, which one is most important priority for you? How are you going to handle these two lives together, especially when the patient is placed in a situation who has refractory hypoxemia?
Priority is always the mother.
So priority is always the mother.
Yes.
Okay.
So first stabilize the mother, then we can go ahead for the fetus.
Very well said. So the idea is that the resuscitation of the fetus is dependent upon the resuscitation of the mother. So that is what we are trying to do. We are trying to resuscitate the mother. And obviously when you have a mother who is well oxygenated, well perfused, having normal H plus ions, not hyperalkalotic or not acidosis, then you can expect
We have to prevent the factors which will compensate the uteroplacental infection.
uteroplacental infection. So idea is that if you have a normal physiological variables for your mother, you can expect the normal physiology for the fetus as well. Okay, so that's very good, very well said. Anything which you feel is like, you know, if you do a prone ventilation, Dr. Ankit, and maybe Dr. Munashir also, we generally have a safe checklist, which means there should not be any absolute contraindication, there should not be any relative contraindications. Relative, they are always relative, which means you can always weigh the risk versus the benefit before you are going to execute it. But the patient who is hemodynamically unstable, the patient who is on vasopressors, do you think they are in the safe category where you can prone them? And what is your experience? I would like to know from each one of you their experience. When you have a patient who is having a refractory hypoxemic respiratory failure, plus also has circulatory instability, which means the patient is on vasopressors, the patient is also having a shock. So how you decide that my patient has to be prone in this case, versus in this case I would like to give more respect to the hemodynamics and I should avoid doing the prone ventilation?
Yes. Although those who are having refractory hypoxemia, and those who are, although it is a relative contraindication, when the patient is on unstable, hemodynamics are unstable, it is a relative contraindication to prone this patient. But case to case basis and taking the risk benefit risk.
So case to case basis, risk versus the benefit analysis.
If the patient is on 5 to 10 microgram per minute of norepinephrine, we can take the risk of proning this patient.
So if the patient is on low dose of vasopressors, you can take a calculated risk. But why you want to take risk, Munashir? I just wanted to know, when your patient is hemodynamically unstable, you don't want to do any further harm to the patient by making them right lateral, left lateral or prone, because the patient who is hemodynamically unstable, they are autonomic, they have autonomic dysfunction, they have autonomic lability. So if you're making them proning, you can trigger arrhythmias, you can trigger hypertension in them. So why are we taking so much of risk in them? What do you think?
First we have to stabilize her lungs. Primary concern was her PF ratio was less than 100. In that case we have taken a decision to prone. So if the primary concern is treated, I think the subsequent things also will get corrected.
And if you correct the hypoxia, hypovolemia, hypercarbia, acidosis, if everything, if in the milieu, if it is in favor of the patient, we can take a risk of proning these patients.
No, I understand. It's a great, the concept which you as well as Munashira has said. And what I really like about you, that what you're saying, that even if the patient is unstable, one, you should follow a protocolized systematic approach. You first take care of airway, you stabilize the airway, you stabilize the breathing. When I say breathing, it means oxygenation, ventilation, and then obviously you talk about the circulation. Having said so, I really like your the point which you have addressed, Dr. Ankit. If you find that your patient is hemodynamically unstable because of the severe hypoxemia. Now somebody can ask, how can severe hypoxemia can trigger the patients to become hemodynamically unstable? So when you have a severe hypoxemia, right, there is a significant HPV which happens with them, hypoxic pulmonary vasoconstriction. And these kind of cases, they have extraordinary high pulmonary vascular resistance. If you measure the PVR in them, it's going to be very high. So when you have a high PVR, the afterload to the right ventricle is going to be significantly high. And that is why they have acute cor pulmonale.
Yes.
Moreover, in order to treat the patient who are severely hypoxemic, you give them extraordinary PEEP. Now this PEEP also increases the afterload to the right ventricle. So when you have these two important things which are placed synergistically, they have a tendency which can lead to decompensation of the right ventricle in the form of an acute cor pulmonale. So if you have any means, which you both have said, if you have any means by which you can improve the oxygenation of the patient, which you're trying to do by making them prone, and you can reduce the PEEP, because once the patient gets recruited, obviously you can reduce the PEEP in them. You're reducing the RV dysfunction or the acute cor pulmonale, and somewhere you're trying to improve the hemodynamics as well. And we have seen very commonly, once you make them prone, not only you improve the physiology of the lung, you also improve the physiology of circulation. But as you have said, the patient should not be having so much of instability that the patient is on triple vasopressors and the patient is just maintaining the circulation. So those kind of cases should not be done. But wherever you feel that the reason of hypotension is also partially contributed by the hypoxemia or the acute cor pulmonale, apart from, let's say, maybe the LV dysfunction or the increase in the ACR which happens in a patient with sepsis and the septic shock, wherever you find that there is also a significant blood in the form of RV dysfunction which is adding to your hemodynamic instability, those kind of cases should be given a trial of coagulation, right? So what is the protocol which you do, Dr. Manashira, in your ICU? How you prone them, how you keep them prone, and what time frame you keep them, and any specific precautions you see you follow? So would you like to enlighten us?
To go ahead with prone ventilation, first we need to take one person, the team leader. Actually, there should be a team for prone ventilation. The team leader should be at the head end of the patient to secure the tube. First, secure the tube properly, and then once we are proning the patient, make sure her abdomen is free, her eyes are properly covered. Why the eyes are need to be covered? Because to prevent the post-operative vision loss, which is a common entity which we deal with.
Maybe not the post-operative, but because of the direct pressure effects. Direct pressure effects which can lead to central artery
occlusions, and
occlusions,
then
venous and arterial
yes,
occlusions.
then she might land into
So I really like your point. What you said, there has to be team.
yes.
So we need to understand that proning is basically a procedure or a skill which has to be executed by team. It's not a one-man army race. That is one. Second, Dr. Manashira, because I did my training in ATLS, they refer this technique as log roll technique, which means the head, the torso, the upper torso, the lower torso, as well as the limbs, they both has to be rotated in a one fashion, in a one
Like a
log
log,
roll, like a log of, like a roll of the log, or the log roll basically. So idea is that there should not be undue flexion or extension or rotation. Yeah. So that is where you have to minimize energy. And as you said, we have to make sure that you are going to lose the airway in case if the person is not cautious about handling the airway. So one person has to be dedicated for the airway, the device has to be secured, maybe the person has to reinforce with the help and fix, and the other person has to fix the torso, the third person has to fix the pelvis, and the fourth person has to be on the leg end, and the patient has to be rotated or has to be prone in a one position, right? So number of hours, what you follow in your
We
ICU?
usually follow 12 to 16 hours of
12 to 16 hours.
Yes, followed by 6 to 8 hours of supine position, then
6 to 8 hours.
followed by
Do you also follow the same protocol, or you have any difference? 12 to 16 hours. In other words, would you like to stretch in certain cases, or you keep 12 to 16 hours? 12 to 16 hours. 12 to 16 hours. No, why I'm saying, because I generally do for 16 to 18 hours, but I also stretch in certain segment of population where if you supine them, the risk of dying in a supine position is high risk. So my patient is in prone, ideally it should be supine, but if I can anticipate and if I can discover that by making them supine, the risk of death is going to be significantly higher. For example, let's say the patient is on high dose of vasopressors. Let's say the patient in prone, despite of in prone, the patient continues to be on high FiO2 levels. So the moment, even if you make them supine, they're likely to deteriorate further. So they may not even tolerate for 6 to 8 hours, as Dr. Manish has said. So those kind of cases, I'd like to stretch them extra. But having said so, I agree with you that we must supine after a defined interval, because you have to identify the patient having any pressure injuries. Also, you have to make them awake. Nerve injuries, very important. Direct pressure effects. Cervical torsion can lead to the thinking of the occlusion of the arteries and the veins, which can affect your cerebral venous pressures and ICP. And recently we have discovered one case after the prone, the patient has a raised ICP to the extent that the patient never wake up. So that is one. So if I have to summarize, or maybe Dr. Ankit can summarize what is unique about this case, and what is your plan for this prone ventilation, who is otherwise a pregnant lady, 28 weeks period of gestation. So can you just summarize?
Unique thing about this case is this. First of all, ARDS is a difficult case and difficult to manage. Everybody is not so comfortable in proning supine this patient. So first of all, prone itself is a challenging case.
So prone is a challenge. Very
Second
nice.
thing, patient is pregnant female.
Pregnant patient, pregnancy itself is a
Itself is
challenge.
a challenging case.
Dealing with two
lives,
patients.
yes.
Two patients is
This
a
is also one
challenge.
of the challenge. And patient is still requiring hydrotrope supports. So patient is hemodynamically unstable. This is also
So
one
it's
of
not
the-
a single organ dysfunction. Your
Yes.
autonomic system is involved. Your patient is also having a kidney dysfunction. I saw the creatinine is 1.5, and obviously the patient has severe ARDS as well, right?
So such kind of cases may lead or may head towards the multi-organ dysfunction.
Multi-organ dysfunction. And what do you think is the possible diagnosis for ARDS in this case?
This is a mostly viral pneumonia leading towards the ARDS.
So I agree with you, Dr. Ankit, because a lot of influenza-based illness, H1N1, we are seeing right now. And I would also like to know if Nitesh or anybody of you who would like to express their experience with the prone ventilation. Anyone of you? If you would like to share, what about you? Have you gone through prone ventilation? Have you experienced the prone ventilation? So Nitesh, what do you think?
So in this case only, after doing prone position, patient PF ratio has improved.
Can you remove the mask and be loud, because I want you to be recorded.
So after doing prone positioning, the patient PF ratio has improved.
So PF ratio,
Before it
which
was
less than
36,
100.
43.
Sorry, what was? Can you repeat it?
Sir, on 100% FiO2 settings, the patient PO2 levels were 36, 43. But after doing prone position, PO2 was 136.
So a dramatic change.
Yes, sir.
So
And
as
today
Nitish
morning
has
was
said,
77.
So you
it
have
has,
witnessed.
patient has improved.
Excellent, excellent. Thank you. So as Dr. Nitish has said, that there is a remarkable change in oxygenation status the moment the patient has been made. Now, why I want to stress this case today in the compendium, and why I felt that this kind of a case should be shared in this meeting. Pregnancy, by and large, has been taken as a contraindication for the prone. Now, as Dr. Nitish has said, Dr. Ankit has said, and Dr. Mona Shira has expressed their views. Now, if you would not have known this patient, you would never ever been able to improve the oxygenation of this patient. And it is the oxygenation or the problem with the oxygenation which has a tendency to kill the patient immediately rather than any other disease per se, right? So maybe in the past there was a relative contraindication, but if your patient, irrespective of whether the patient is having a pregnancy or not, if your patient can be stabilized or can be improved in terms of airway, in terms of breathing, in terms of ventilation, oxygenation and circulation, all this kind of cases should be given a trial of the ventilation and a possible mortality benefit as well. With this, I would like to, anybody who would like to express anything? Would you like to share your experience? And then we will close this meeting.
Even in last case, I have seen the patient got improved after proning, and his saturation.
We're talking
improved.
about bed number 4.
Yeah.
Ah,
bed
so
number
there was
4.
one case.
One case, and a lot of improvement in saturation. So got better result with that.
Very nice. You remember, if I correctly remember, at what time you intubated that case? Because the patient was having a PF ratio which was less than 100, the patient was having a respiratory failure. You tubed the patient and you immediately resorted the patient onto the prone ventilation. To the extent, what was the name? Chanchal Rani? Rekha Rani. That the patient actually, after 9 days of mechanical ventilation support and after a total 16 days of stay with the hospital, the patient got discharged.
4 cycles of prone.
4 cycles of prone ventilation. So you yourself has done actually this exercise. So with this, I would like to bring closure. And Sandeep, anything which you want to address? कुछ शेयर करना चाहोगे संदीप? संदीप हमारे नर्स हैं जो इस एक्सरसाइज में हमेशा इन्वॉल्व रहते हैं और संदीप एक्सपर्ट हैं फॉर डूइंग अ प्रोन मेडिटेशन। कुछ शेयर करना चाहेगा संदीप? प्रोन के साथ कंफर्टेबल है संदीप प्रोनिंग करने में?
Yes.
अगर किसी का ऑक्सीजनेशन बेटर नहीं है, किसी का O2 लेवल्स कम है, CO2 लेवल्स अगर हाई है और ऐसे पेशेंट जिनके एक्सरे बहुत खराब है, तो उन केसेस में आप क्या करते हो?
प्रोन ही कर सकते हैं, उससे हमें अच्छा रिजल्ट मिलता है और ज़्यादा केसेस में हम लोग सफल भी हो
हैं। इनफैक्ट मैं ये बताना चाहूँगा कि मैं या मेरी टीम या हमारी टीम इससे पहले कि प्रोन के बारे में सोचे, संदीप और उनकी टीम पहले ही ये बात डिसाइड कर चुके थे कि इसको प्रोन से ही बेनिफिट मिलेगा। ये इस लेवल तक वी हैव बीन एबल टू रीच। दिस इज अ लेवल ऑफ एक्सरसाइज, दिस इज अ लेवल ऑफ कॉम्पिटेंसी we have been able to receive in this exercise. Now Muskan, I want you to have a look over the patient. How the patient is placed in prone ventilation. So this is the patient who is in prone ventilation, and if you can see, can you focus on the face? Just do it from that side. So the patient, this is head and neck. The eyes are covered up. This is a tube which the patient is having. Obviously the eyes, they should not be under the direct pressure effects. And if you can see, these are the pressure leads. And if you can focus on this abdomen, so from this side, because there you have an ice packs, abdomen is visible. So if you can see, the abdomen is free. Is it visible, Muskan? So abdomen has to be free, and the bolsters or the pillows has to be under the pelvis, not over the abdomen. The abdomen has to be free. Otherwise, the direct pressure effects related to direct pressure effects, your patient may invite uteroplacental insufficiency. And if you can see over the monitor, now the FiO2 which was on 100% has been reduced to 40%. Your PEEP has been reduced to 8, and obviously your airway pressures, you can see they are just 45. And even if you can see over the vitals,
It's visible. It's visible.
no problem, let me do it. So on 40% the patient is having a SpO2 of 95. The patient is hemodynamically unstable, requiring a vasopressus. Patient continues to be tachycardic because the patient is continuously febrile. But we are hopeful, and I think in the next 4 to 5 sessions, which we are expecting this patient to be there on the cycles of prone therapy, we expect this patient also to be discharged, and maybe this case will also be recorded like we did in the last case. Thank you for listening to us. Thank you.